It's really a pleasure and a delight to be here, and to our audience from points near and far. Welcome. Good morning, afternoon, evening, or whatever time of day or night it is for you. This is the document that was published in JACE in the January issue, the first 27 pages for 2017, actually. This is a consensus document that was about 4 years in the making. John Simpson is the first author on this document from Evelina Children's in London, UK, and a whole group of other folks from all around different centers in the US and in Europe. I'm going to start by acknowledging the enormous work that John put into this project, and really all of my co-authors. The document was vetted by the EACVI Scientific Documents Committee, the American Society of Echo Guidelines and Standards Committee, the ASC Board of Directors, external reviewers as well. And it was published initially in the EHJ, European Heart Journal Cardiovascular Imaging, in October of 2016, and then published in JACE as we discussed. None of the authors have mentioned any actual or potential conflicts of interest in this. Now, the goals of this presentation are quite ambitious. Our goal is to try to cover all aspects of the document, starting with technology, going on to data acquisition and workflow, image display orientation, talk a little bit about image-guided interventions, quantitation, training, and areas for advancement. The way that the document is structured is this is a joint document, and so it shares characteristics of both of the individual styles of these two bodies. It is meant to complement rather than duplicate adult 3D echo guidelines, and each of the sections that we talk about includes recommendations for current use and our recommendations for future directions specific to that section. This is meant more as a request to our colleagues in industry because we need their help to be able to bring 3D echo more into the mainstream. And finally, there is a large appendix of supplementary material that's available online, and that includes a 27 megabyte PowerPoint presentation with images. I have only a few of those that I'm going to be showing you, but folks are welcome to look through that presentation as well. So let's jump right in. One of the biggest things with the 3D echo that's a big difference has to do with the transducers. These are matrix array transducers that are typically cut from single crystal, resulting in over 3,000 elements per transducer head, and with connections to each of those elements that is less than the thickness of a single human hair. In addition to the advances in transducers have come advances in parallel processing as well as progressive miniaturization. Miniaturization in particular has led to the development of the pediatric 3D transthoracic echo transducer and the adult 3D transesophageal echo probe, both of which are now about almost a decade old, actually. The next thing we're going to talk about is workflow. So what we would like to ideally use is a combined 2D and 3D transducer. Not that we just have one transducer for all patient sizes, but for any patient size, we should be able to switch between 2D and 3D echo imaging without any difference in the quality of the image. This turns out to be a particular challenge in pediatrics because high-frequency pediatric 2D echo transducers are widely available, whereas the 3D transthoracic transducer that's available for pediatric usage has limited transducer frequencies. As a result, we are somewhat constrained in our ability to obtain super high quality images in with 3D transthoracic echo, especially in little babies. The pediatric 3D transesophageal echo probe is limited to patients who are above 30 kilos in weight. Those are the recommendations from the manufacturer. Under general anesthesia and depending on the habitus of the patient, many of us have been able to do these without having any problems in patients down to 18 kilos. A little bit about the modes of data acquisition. There are several modes that are available for 3D echo, and the nature of acquisition really depends on the clinical question that is being asked. So the primary issue that we have to address is, what is it that is important? Is it field of view that is important, or is it detail that's important? So the wider the field of view and the deeper the field of view, the less likely it is that your spatial resolution or your temporal resolution is going to be all that great. And then one of our challenges is that unlike two-dimensional M-mode pulse wave or color flow Doppler or continuous wave Doppler, the nomenclature and the configuration of specific acquisition modes in 3D echo is unfortunately still vendor dependent. This is really a challenge, and it is hopefully something that will get fixed. A little bit about some general principles. Some of the laws of physics just cannot be overcome. So the wider our range of interest, the lower the temporal or the spatial resolution would be. And the seesaw that we are on is trying to figure out how to enhance volume rate, which is the three-dimensional version of frame rate, versus line density. So let's talk a little bit about some of the enhanced 2D imaging capabilities that are provided by 3D transducers. Because these are matrix probes, we are able to electronically rotate the imaging plane. So from a parasternal long axis view, one could basically electronically rotate the plane rather than rotate the entire transducer. And this can be done as a single plane, or it can be done as multiple simultaneous two-dimensional cut planes. And this is actually something which is quite useful to look at ASD and VSD size and shape, ASD rims, AV valve morphology, and regurgitation. And one of the challenges to keep in mind is that the temporal resolution with multiple simultaneous 2D cuts is usually going to be half that of the original 2D acquisition. So here's an example of a parasternal long axis in a patient with mitral regurgitation, where you see what appears to be a single jet in a parasternal long axis view, but you notice the cursor at the bottom here, and basically we're going to be cutting this in a plane that is 90 degrees orthogonal, clockwise rotated from this, and this shows you this is actually a pretty wide jet that has, that goes almost through the entire area of coaptation of the leaflets. We'll move on to real-time 3D echo or live 3D echo. The way to define this to me is that the image appears when the transducer is in contact with the chest, and it disappears when the transducer is lifted off. Because this is real-time, we are not stitching together any sub-volumes, and that's the biggest advantage of live 3D. So you end up minimizing the need for the patient to cooperate. When you're talking about children, we have no risk of stitch artifact. One of the challenges with live or real-time is that the field of view or the volume rate are going to be narrower or lower respectively. Real-time 3D echo is typically used during catheter interventions. Typically it is what you see is what you get. There's not really a whole lot of room for cropping or for doing anything other than maybe tilting the image or changing your gains or something to that effect. This is an example of a live 3D echo image on a patient. This is actually our first patient on whom we did a 3D transesophageal echo. This was an adult who had post-myocardial infarct VSDs. and we've cut the back of the heart off, and we're looking from behind forwards. So to our left is the mitral valve, in the middle is the aortic valve, and to our right is the right ventricle. So you see the plane of the ventricular septum. One device has already been released, and the other device is about to be pulled into place. So it's a beautiful example of the kind of images that we're able to obtain with real-time 3D imaging. On the other hand, full volumes are what could be called as ECG-Gated multi-beat acquisitions. Again, we are plagued by nomenclature here. This is a modality that is used frequently in pediatric 3D echo. This provides for a large field of view and actually gives pretty good temporal resolution. It consists of electronic stitching together of sub-volumes over 2 to 6 beats. So the analogy would be while a live 3D image is kind of like one little piece of an orange, this would be like 4 little pieces that are stuck together. One of the challenges with full volume acquisitions or multi-beat acquisitions is that there's a potential for stitch artifacts with breathing or with movement of the patient, or when there is an active precordium. Attempts have been made to try to minimize this, but it remains a challenge in pediatrics. Manufacturers have introduced the concept of a single beat full volume, but the challenge with that is that there is a fairly limited temporal resolution, especially in children who typically have pretty high heart rates. The multi-beat acquisitions typically require post-processing, and they're not amenable to immediate interpretation. So here's an example of an acquisition of a severely regurgitating tricuspid valve. So this is obtained from parasternal long axis view, and you see the non-coaptation right here. In the orthogonal view, you see the parasternal short axis view, and here you see the two-dimensional ANFAS, and here you see the three-dimensional ANFAS view looking at this from above downward. So this is the plane of the ventricular septum. This is the septal leaflet of the tricuspid valve. This is the posterior inferior leaflet, and that's the anterior leaflet of the tricuspid valve. All of that black stuff there, the big triangle, is the area of non-coaptation. It would be very difficult to be able to obtain this kind of an image in a single beat live 3D image. So this is where full volume acquisitions prove to be quite useful. 3D color flow can be added to either a live or to a multi-beat acquisition. In these, the color data is separate from the grayscale data, so there are two separate data sets. And really, one of the important things to remember is that in order to visualize a 3D color flow, you have to suppress the grayscale data. If you're looking at valve regurgitation, you really have to crop in to be able to look at where the valve is and where the regurgitation is in order to for that to make sense. On then to the principles of acquisition for 3D echo. So the first and most important thing here is attention to the quality of the two-dimensional echo image. We like to use as high frequency 3D transducer as possible. There are only two choices here, and so you just have to pick between the two of them. We like to keep our sector width as narrow as we possibly can to try to enhance our temporal resolution. And keep in mind that resolution is the best in the long axis of the transducer, in other words, in the axial plane. It is interim in the intermediate in the lateral plane, and it is the lowest in the elevational plane, which is the newest, the third plane that's been added by 3D echo. It is important while acquiring 3D images that the imager review multiplanar images in order to ensure the quality of the data, and they do that before they do the actual before they hit the acquire button. Some tips for acquisition are that when we're talking about relatively static structures, such as looking at ASDs or VSDs, the modalities that work best are either live 3D echo or 3D echo zoom. We like to optimize our gain in order to avoid holes or noise. Holes are pretty common in thin structures such as valve leaflets, and by that I mean artifactual holes, not actual holes. Noise is something that is very common in if one uses the baseline presets for acquiring a 3D image. And they result in a kind of view that is akin to looking through muddy water. So everything just looks kind of fuzzy. And then the next thing that I'll point out as an acquisition tip is really critical to try to rotate the image, whether from top down or from left to right, and to tilt them, again, whether from up to down or from left to right, in order to enhance perspective. Keep in mind that if you just look at the if you look at the image straight up, it will just look like a 2D image. So you have to tilt it in order to understand the third dimension, because we are still not blessed with holographic displays. So here's an example of parasternal long axis full volume acquisition that has now been cropped in order to look at the image. And what you see here is you can't really see the cavity of the left ventricle. This is an overgained image, and this is what that same image looks like when one decreases the gains. So if when you get an acquisition, it looks like something, it looks like the image on the left-hand side, where you cannot see the details of the mitral valve, papillary muscles, and the cords, and in fact the ventricular septum in the depth of the image, because all of that blue stuff there is part of the holographic color map for these images, where orange is in the near field and blue is in the far field. If you can't see any blue, you got to decrease the gain until you can see that. If the image looks fuzzy, then you have to decrease the compression so the image looks more crisp. So you see how the endocardium looks a little bit fuzzy here and looks more crisp on the right-hand side image. That's because the right-hand side image has been optimized. The next example is what it does when you tilt the image. So this is a parasternal short axis view looking at the mitral valve, or trying to look at the mitral valve. Most folks who are grounded and schooled in 2D echo would find this quite reassuring, because it looks like a two-dimensional echo image where the aortic valve is in the middle and the mitral leaflets look like what they look like by 2D. But if that was the goal, then one shouldn't be using 3D at all. One should just use 2D. If you really want to look at what the substance of the anterior mitral leaflet looks like, which is it doesn't look like a line, it looks like a sheet, then it's a very simple matter of grabbing hold of the trackball and tilting it towards you, so that the entire image is tilted towards you, and then you're able to see what in this case is the anterior surface of the anterior mitral leaflet. So this is a very good example of how a small maneuver like tilting the image can make all the difference in terms of the imager's ability to appreciate what is going on with the third dimension. We'll go on now to talk about display modes with 3D echo. The first of these is volume rendering, the second is surface rendering, and the third is multiplanar reformatting. So volume rendering is what we use when we crop 3D images. It's similar to the kind of image that we just saw in the previous two examples. Here the focus is intracardiac anatomy in a three-dimensional image. And the second kind is what's called surface rendering, and this is used primarily for ventricular volumetrics and also to look at valve function. So it's ventricular function and valve function that are primarily the targets for surface rendering. And the third kind of display mode is multiplanar reformatting. This results in a quad screen display of the data, and we saw this a little bit earlier. Here, you're able to adjust the planes in each of the two-dimensional images on the screen, and as you adjust those, it can help with understanding complex anatomy, and it helps make measurements of valves, septal defects, and vena contracta. So you're able to get novel two-dimensional images and cut planes of various structures in order to be able to make measurements that are clinically relevant and that make sense. Our hope for future directions in this area consists of improved temporal resolution of one-beat acquisitions and strategies to deal with stitch artifact. Our recommendations are that the acquisition for 3D echo be tailored to the clinical question, and that high-frequency 3D transducers be used in infants and in young children, and when you're using epicardial 3D echo. If 3D transthoracic echo proves to be insufficient or inadequate, then consider 3D transesophageal echo when patient size permits. Next, we're going to go on to image orientation. 3D echo facilitates en face views of the septums and the valves. So, in a very simplistic manner, you can look at these structures, intracardiac structures, either from above looking down or from below looking up. For example, imagine looking at the AV valves with the top of the heart cut off. So we cut off the atria and look down on the AV valves, or on the LV outflow tract of the aortic valve. Or you could do the same thing looking from below upwards. Look from the ventricular aspect up. The next is, you could look from the right side looking leftwards, or from the left side looking rightwards, for example, at the interatrial septum or at the interventricular septum. And the final viewing perspective is from the front looking to the back, or from the back of the patient looking towards the front. An example of this would be the four-chamber view that I showed you in the very beginning with the transesophageal orientation. Next, we're going to talk about image orientation, and this is key. So this is one of the big discussion points and key learning points from this presentation, that because 3D images are able to be rotated in the Z-plane to achieve the desired rotation and orientation, the consensus in the group is that we adopt an anatomically correct orientation rather than a two-dimensional echo standard orientation. So the orientation of the images then becomes consistent with what is seen with MRI or CT angiography. So the heart is projected in the same orientation as with a patient who's standing upright. So in other words, superiorly positioned structures anatomically are going to be positioned uppermost in the image. Here are examples of how that looks. So this is a subcostal long axis view that is really quite familiar to us. And here, there is no real difference with the way that we would project this image. This is very similar to what we do with subxiphoid imaging, even with two-dimensional imaging. On the other hand, this is quite different. This is, we've cut away the free wall of the right atrium, and we're looking from right to left at the interatrial septum. The superior vena cava comes in from above, inferior vena cava comes in from below. The asterisk mark where you would see a secundum atrial septal defect. You see the mouth of coronary sinus over here, the tendon of Todero, and the tricuspid valve. So this is the preferred orientation when we're talking about 3D echo for the interatrial septum. And this is the preferred orientation for the subcostal view of the ventricle. Here now we're looking from above down at the left atrial appendage, the mitral valve, and the aortic valve. And this is an en face view of the interventricular septum. Notice that the heart is not standing on its apex. It is actually tilted in a way that makes most sense with the superior structures to the top of the image and inferior structures to the bottom of the image, because the heart is not vertical in the human chest. The original orientation of this image with the SVC coming in and the IVC coming in looks something like the left-sided image with the asterisk marking the interatrial septal defect. That image is now rotated in the Z-plane here, where the SVC is on top, IVC below, and you see the ASD quite clearly. Next, we look at the right and left atrial aspects of an ASD. So this is look from the right side looking leftwards at the ASD, and this is from the left side looking rightward at the ASD. Again, we maintain the anatomic orientation with superior above as the volume is turned. Next, we'll talk about the surgical view. So this is done as if the patient is supine with a surgeon operating from the right side, where the view is from the patient's right side looking leftward and inferiorly, or leftward and posteriorly and inferiorly, not really from above down. So the surgical view is a little bit of a tricky view, and we just have to be a little bit careful about using that term indiscriminately. As far as future directions in terms of 3D image orientation, we've been asking for many years for orientation markers. We'd love to get the ability to landmark or label structures so that once you label something, the right ventricle, the label rotates with the rotation of the image as you start to rotate it around. And finally, fusion imaging, not just of 3D echo with CT or MRI, but 3D echo with other 3D echo data sets. That's an approach that's been tried in the UK with some success. And finally, our recommendation is an anatomic approach to the display of 3D echo images. So next, we'll talk about optimal projections for different lesions. Now, if we try to get into the details of this, that would probably take us until into the night. So I'm just going to refer you to table 1 here. The area of interest should be well seen on 2D echo. Insonation should be performed orthogonal to the plane of the area of interest. It is important to include clinically relevant adjacent structures in order to avoid being lost in space. And finally, we need to be sure to optimize acquisition depth and width. In evaluating anatomy, 3D echo complements, but as of now, still doesn't replace 2D echo. The primary uses of 3D echo structurally are valvar defects, septal defects, and complex connections. And these are summarized in tables 2 and 3 with plenty of references. Next, we'll go on to 3D echo and catheter interventions. So 3D TEE is rapid, it's useful, and it's unique. It provides unique perspectives. One of the key things with it is you have a limited amount of time as the operator. So you really want to try to use live 3D echo or live 3D zoom, and also use multiplanar 2D imaging, as well as plain old 2D imaging. There are some sites and some in the group who like to use full volume acquisitions for the big picture view that they then end up manipulating while the intervention is in progress, when they don't need us to be doing stuff, so that we can show the interventionalist the images, and then we follow that with live imaging to guide the procedure. 3D TE provides for on-fast views of the septum and devices, which are really quite useful. Specifically, it is helpful if you have patients who have multiple defects or irregularly shaped defects or residual defects. So patients who have, for example, fenestrated interatrial septum or elliptical things, or we're trying to figure out whether you have multiple defects or strands, that's really where 3D comes into its own. Future directions for image-guided interventions include, of course, our holy grail, which is pediatric 3D transesophageal echo. We'd love for views to be automated, and we'd like for 3D intracardiac echo probes to also be available. And we've talked about fusion imaging already. So overall recommendations in this area, 3D TEE is recommended to guide device closure of selected atrial and ventricular septal defects, especially if they are multiple, irregularly shaped, or if they happen to be residual defects. And real-time or live 3D is recommended to visualize catheters, delivery systems, and devices during interventions. And finally, we recommend the use of multiplanar reformatting or full volume 3D echo to actually measure defects. Next, we're going to go on to 3D echo for ventricular volumes and function. Now, this can be challenging in congenital heart disease because of cardiac malposition and complex spatial relationships. By and large, this has been validated more for the left ventricle than for the right ventricle, but it has been and for both. The importance of this is because volumes and function are increasingly used to plan management because subjective assessment is just simply unreliable. Let's talk about specific situations. So the right ventricle is always our challenge, and it is our obsession. It's an anterior ventricle. It's located retrosternally. It has this complex boomerang-shaped architecture. It has prominent trabeculations. The subxiphoid window is limited beyond childhood, and yet 3D echo could really have an important role to play here because formulas have limited validity in measuring ventricular volumetrics of the right ventricle. 3D echo makes less assumptions regarding RV shape. There are several approaches for measuring for RV volumetrics. The first of these is summation of discs. This is conceptually most similar to MRI, and it actually correlates well with MRI. Unfortunately, this mode has been discontinued. It is not available with current software packages. This is truly unfortunate, especially for patients with congenital heart disease. The next mode is a semi-automated border detection mode, where a full volume of the right ventricle is acquired, and it is projected in a triplane mode as 4 chambers, sagittal and coronal. It requires that the operator identify key landmarks within the right ventricle and the left ventricle, and based on those landmarks, and then the operator will have to draw contours of the RV in end diastole and in end systole in each of these 3 views, thus constructing a dynamic right ventricular polyhedron. This approach is feasible. It correlates well with MRI, but it generally tends to underestimate volumes. Acquisition times are shorter with this than they are with MRI. It has good inter and intra-reader reproducibility. However, because it tends to underestimate volumes, these volumes cannot be used interchangeably with MRI measurements. The next approach is knowledge-based reconstruction. This is an approach that uses 2-dimensional acquisitions and a magnetic tracking system. So, to be clear, this does not require 3D transducers, but it does require separate hardware. It requires identification of right ventricular anatomic landmarks, and it uses a database that is based on MRI and is actually specific to the reference lesions. It has been validated following tetralogy of fellow repair, as well as in pulmonary hypertension and in adults with a systemic right ventricle. Knowledge-based reconstruction requires a tracked ultrasound transducer. The patient has to remain still throughout the study, and it is time-consuming. Next, we'll go on to 3D assessment of the left ventricle. So for this, we require an apical or a modified apical transducer position that includes the entire volume of the left ventricle. It requires adequate image quality and good acoustic windows. The user ends up defining key reference points in the left ventricle, and then the software performs semi-automated tracking of the endocardium. Fortunately, this can be overridden. 3D volumetrics of the LV are more accurate than M-mode or Simpson's biplane. It has been shown to be as feasible as is 2D echo in children. It has been validated in newborns and in infants. And just a couple of caveats. One is that in children, the good news is that our image quality tends to be better with the left ventricle. The challenge is that high heart rates and smaller left ventricular volumes are potential sources of error. However, 3D has proven accuracy versus MRI across the age spectrum. It compares favorably with MRI overall. It has a bias towards lower volumetrics once again, and it has good repeatability, but it is not interchangeable with MRI. There are hundreds of references that provide the data that these conclusions are based on, and you all are encouraged strongly to read through those in the review article. Next, we'll go on to the kind of ventricle that everybody in pediatric echocardiography would love to be able to work with, which is the functional single ventricle. For this, the best approach would be disc summation. Now, semi-automated border detection has been used. The problem with it is it's very difficult to make up reference points for a non-existent other ventricle when you're talking about a single ventricle heart. And this approach systematically underestimates right ventricular volumes. The future directions for volumetrics include the fusion of multiple volumes in 3D echo in order to acquire the entire cavity of the right ventricle. The next is, while this might sound rather retro, the availability of a method of discs would really be desirable for our field. And it would be great to have large studies that provide normal values across a wide range of body sizes in order for ventricular volumetrics to be brought into the mainstream. Another future direction is it would be great to have automated and reproducible algorithms because that would give us geometry-independent volumetrics for congenitally abnormal ventricles, and that would truly enhance the application of 3D echo in serial follow-up. It would make a clinical difference. So on to recommendations of volumetrics. So 3D volumetrics is highly reproducible. It has a systematic bias versus MRI. It underestimates volumes. So those two modalities are not interchangeable. The clinical adoption of ventricular volumetrics is hampered by lack of normal data, and software for the normal LV or the RV should not be applied to abnormal ventricles without validation. We'll move on to 3D echo of the AV valve. So this is one of the most frequent clinical applications of 3D echo, where the questions have to do with valve size, anatomy, function, and then the substrates and the dynamic mechanisms of valve dysfunction, things like size, number, and shape of regurgitant orifices, and so on. So when we look at AV valve anatomy by 3D echo, the modality allows us to systematically assess the annulus, leaflets, cords, papillary muscles. Keep in mind that commercial software assumes that all valves are like a normal mitral valve in their morphology, and that's a bit of a challenge for most pediatric valves. The next thing is that quantitative software for the AV valve in atrioventricular septal defect or AV canal defect, as well as for the tricuspid valve in hypoplastic left heart syndrome, has been reported by a couple of groups, most notably the group in Edmonton. But this is a research-based quantitation, and unfortunately, these types of software are not clinically available. Therefore, 3D echo of AV valve anatomy today remains a qualitative assessment. Now, for AV valve regurgitation, 3D can be used to measure the area of the vena contracta perpendicular to the regurgitant jet. This can be done beautifully using multiplanar reconstruction, reformatting, and there are multiple validation studies in adults with mitral regurg comparing 3D echo to MRI. We don't have pediatric or congenital heart disease validation for quantitation of AV valve regurgitation yet, and that would be good to have. So recommendations as far as the AV valves go consist of using 3D echo to visualize the AV valves, PAPs, and caudal support in order to assist surgical planning. Using 3D echo for the location, size, shape, and number of regurgitant jets as well as orifice area is key. And then 3D measurements of the regurgitant orifice area really requires validation in children and in patients with congenital heart disease. Finally, that the software for quantifying valve anatomy and function should be used with caution because of the assumptions that all valves are mitral. I'll briefly mention 3D echo of the arterial valves. The role of 3D echo in aortic valve disease consists primarily of LV volumetrics and ejection fraction, measurement of the aortic annulus diameter or rather circumference and the aortic root circumference and area. MPR images can be obtained for the effective aortic valve area as well. It is difficult to visualize the leaflets of the arterial valves because they are quite thin and they are quite susceptible to artifactual holes and so on. As far as the pulmonary valve goes, it's possible to obtain unfast views of the pulmonary valve, and there's no validation for regurgitation of the pulmonary valve. Next, we're going to go on to training in 3D echo. So this is a steep learning curve, and it demands specific training. So it requires a change in mindset. First thing is that while with 2D echo, acquisitions are done in predefined planes, in 3D echo, the data set is acquired, and then there is an extensive potential for post-processing. And this is really key to the understanding of the difference. So the goals of understanding include developing and improving the ability to acquire optimal data sets. Next is to post-process these data sets, both for morphology and for quantitation. The first of these, in my opinion, is best done through trial and error. The second of these is better done in more supervised kind of settings. The next goal is to learn to recognize and evaluate unfast views of valves, septums, and other complex anatomy. One of the key things here is the ability to actually recognize unfast views that are abnormal. Because access to pathology specimens is really limited to some large programs and is, for the most part, very difficult for sonographers to have access to. It is important to have educational programs and books that have side-by-side depiction of pathology specimens with 3D echo images, because this is what really results in changing the paradigm and changing the thought process for the person doing the acquisitions. Because what your mind doesn't know, it's going to be very difficult for the eye to see. So we'll go on to talk about various types of 3D training. So live scanning workshops certainly are authentic, but they are limited by class size and by the availability of cooperative subjects with a wide spectrum of disease states. If you try to do this with normal control patients who have good quality images, it gets boring pretty quickly. There are also concerns about privacy and HIPAA and all of that stuff. Unfortunately, 3D simulators are lacking. Those would be really helpful in order to be able to teach folks how to acquire 3D data sets. What about post-processing? So the format of several workshops consists of teaching attendees how to manipulate data sets from a wide range of pathologies. Now this requires many anonymized, high-quality 3D data sets, a large number of computers, and it requires vendor-specific software. One of the challenges is the frequency with which the user interface keeps changing, and there are variable approaches between vendors. This is a major contrast with two-dimensional echo, where acquisitions and measurements are fairly standardized. And this has become a recurring challenge with 3D echo, where the manufacturers want to maintain exclusivity or just be slightly different from their competitors as far as how exactly the images are to be post-processed. What about center variability? Well, it turns out that there have not been any specific guidelines for training in 3D echo within the guidelines of the Society for Pediatric Cardiology Training Program Directors. 3D echo is also not currently included in the European certification process, and so the current document, we believe, is an important step in that regard. So the basic components, in the opinion of our group, for 3D training include attendance at a formal course that teaches acquisition and post-processing. Then, at the home site, the acquisition and post-processing of at least 50 volumes that include transthoracic and TEE, where your roles include looking not just for abnormal morphology, but also for ventricular volumetrics. And it's really worth considering 3 to 6 months of training in a high volume center. Advanced training should include both cath lab and intraoperative exposure, because the skill sets here are quite different, requiring rapid acquisition and tailored post-processing. We've been working on this with and at the American Society of Echo. In 2016, 4 co-authors of this work, John Simpson, Dave Robertson, Jerry Marks, and myself, conducted a 4-hour workshop at ASE. And we're going to be repeating this on the 2nd of June at the ASE Scientific Sessions in Baltimore on the afternoon of the 2nd of June. Next, we'll talk about, future directions. So in training, we would like to have web-based access to analytics software. This is available quite easily for CT angiography and for MRI. It's a shame that it's not available for 3D echo. It would be great to have an online library of 3D data sets of various lesions in congenital heart disease. And tools for anonymizing DICOM data sets, 3D data sets are really essential. They're not available easily currently. Training in 3D should be an integral part of training for a congenital echocardiographer, both in terms of indication and added value, acquisition, post-processing for morphology, quantitation of function, and recognition and evaluation of unique views. One important recommendation is consistency of the user interface and uniformity between vendors. So let's think a little bit bigger picture in terms of some advances that we would like to see in 3D echo. So we'd like to see some more flexible transducer designs. So for example, highest frequency possible, mid frequencies, some updates in the pediatric transthoracic transducer that exists, enhanced post-processing capabilities, techniques that have been worked on by Dr. Del Nido's group in Boston that have to do with frame reordering and image compounding. These are techniques that lead to significant improvements in temporal resolution and allow an increased field of view and increased endocardial definition, and also permit views of intraventricular flows. Some other advances include 3D printing, which was simply out of the scope of the current document, and holographic displays. Some of these have been demonstrated at medical meetings in the United States as well as in Europe over the past 2 to 3 years. What about advances specific to congenital heart disease? Well, we would like to have the industry help us with validation of novel measures of LV and RV volumes in congenital heart disease, deformation, valve morphology, function, flows, have robust normal pediatric ranges for quantitation across ages and body size, so that we are able to embrace the modality with access to standardized quantitative tools. And key here is inclusion of the right heart, congenitally abnormal ventricles, and valves. So with that, we are at the end of the presentation. So I'm going to try to go through as many questions as I can get through here. I think I see about 15 so far. So the first is there a guide for which landmark should be displaced with each structure or defect, such as always include the coronary sinus while demonstrating ASDs? That's a great question. No, there isn't. The general idea is the more things you cut away, the harder it's going to be, even for the person that did the cutting, to recognize what the heck it is that they're left with at the end. So it's really important to have a lot of landmarks available to you. There's a question about how to select device sizes, and I would rather not get into that. That's something that's more in the purview of interventional cardiologists and the manufacturers of individual devices. Question of whether which side of device size, which side should you use, the right side, the right RA side of the defect size or the LA side? And that's, again, I would report both of those to the interventionalists and leave it to them to decide how to do that. Question about 3D volumetrics of AI. I think we already talked about that. Unfortunately, it doesn't really quite exist. Is there a currently preferred 3D platform? Probably not such a great question for me to try to answer because I'm trying to stay as vendor independent as I possibly can. Next is a question about the use of MPR mode to calculate vena contracta areas for the aortic valve. Absolutely a great idea. No, it hasn't been done specifically. How much extra time do you allocate for a transthoracic echo with 3D? It depends completely on the indication and what the specific question is. Sometimes it's not done. Sometimes just a little bit. Sometimes you end up doing a whole lot. How often do you find that 3D transthoracic echo changes the surgical or interventional plan? Well, I think the answer is probably often enough. It's difficult to answer that kind of thing. There are several studies that have been done from 3 to 5 years ago from various centers that answer that quite well, I think. In general, it just depends on how good the image quality is and how much expertise the imaging team has with 2D echo versus 3D echo, and so on and so forth. Next is, let's see, in the presence of endocarditis with a PA melody valve, what would be the optimal technical imaging aspects for better delineation of device patency? Oh, melody valves are very difficult to actually view, whether by 2D or by 3D echo. I think that the artifact from the stent makes for all kinds of challenges, and I wouldn't bet a whole lot of money with what I see by 3D or by 2D echo inside a melody valve. Question about RV volumetrics, which I think there's I'll refer you to the paper. There are plenty of references there that talk about it. What are recommended educational resources for teaching 3D to sonographers? I think we went over some of this, live, attending didactic sessions. Several of the manufacturers offer these when you purchase equipment from them, and then really getting to workshops and so on and so forth would be helpful. Recommended resources with side-by-side 3D and pathology images. There is a textbook that Roberto Lang and Victor Moravi and Stan Schoenen and I co-edited that does exactly that. In a center that only has software available for normal hearts, what would be the best usage or application for congenital heart disease? I think that the answer to that is I would really focus on anatomy and not on ventricular volumetrics or function. I think you're going to learn a lot with just anatomy. How many pediatric echo labs are currently using 3D protocols? Well, 3D protocols haven't even existed, so it's been, the paper is actually an important step in that direction. And I think it's key to, our hope is that the paper will help galvanize developments in this. Do you think CCI or ARDMS should have a separate test for this or something like that? So I probably should leave that answer to a sonographer colleague and not delve into that because it just seems to be the appropriate thing for me to be politically correct with that. Next is a question about we often don't get the same fancy 3D images which we see in presentations and talks. For example, an infant with tachycardia, respiratory artifact, or ectopic atrial tachycardia. My recommendation is don't even try, because my guess is that in those images, in those patients, your 2D images are probably not that great either. And if they are, I would be happy with them. I won't even try 3D echo in patients who are going to be where you've got problems with infants, with tachycardia, and so on. Having said that, a lot of times the quality of the image depends on, it's really part of the learning curve. So you got to try to kind of, if you're just not successful overall, you just keep on going, keep trying to change some things and see if you can get better with it. Try with the bigger kids, try with adults, try with parasternal and apical views, and then start to go further. Are there any congenital CPT codes? Yes, there are. You can Google them. Is 3D echo more accurate in evaluating the size of ASDs and VSDs? I think that's correct. I got the same question again about tachycardia and respiratory artifacts, and they don't get the same fancy images. I agree with you. I don't either when I've got a baby with tachycardia and respiratory artifacts. Any benefits to using ultrasound contrast agents? We don't use contrast agents because I think that there was a black box warning, and in general, in pediatrics, we don't tend to need that particularly much. Is 3D echo safe for babies below 3 pounds? I guess you might find it useful in a select situation. I'm just completely not sure of what the big clinical application would be with that. Do you foresee any use of 3D echo in fetal echoes? It's already being done, so I think that's pretty good. I got one answer from somebody that said a big uppercase no on an additional test for ARDMS, so thank you for that. Let's see if there are any other questions. There are lots of little conversations going on between people. Somebody missing someone and somebody else missing someone else. It's really quite funny. Anyway, that's where we are. Any other questions? We probably have a couple more minutes for another question or two. How often is vendor hardware and software evolving? Should Echo Labs commit to one vendor and get comfortable with it? Unfortunately, they're evolving quite frequently, and it is quite a challenge. On the other hand, it's like buying an iPhone or like buying a computer. At some point, you just got to do it. And our general approach has been to basically get stuff from one vendor and really just try to enhance one's skill sets as much as one possibly can with that one, because once you learn the basics, then it becomes easier to translate that body of knowledge across to another vendor. I would suspect they're trying to learn the software and hardware from 2 or 3 different vendors. Might be become like a baby trying to become trilingual or bilingual, where it might take several years to get to be expert at all of them. But but the question is, how much patience do we have with trying to learn these different things? Babies don't have a choice; they just have to learn languages, so they just learn them. So I think that's about it by way of the questions and all of that.